This is the ultrasound guided Quadratus Lumborum Block. This block was initially described by Professor Blanco as a novel method to provide greater spread of local anesthesia than the classical transversus abdominis plane block. This block not only have the greater spread of local anesthesia, which means the block allows anesthesia of the thoracic T6 to lumbar alto nerve, and the duration of analgesia is also longer. It also provides loss of sensation of both the somatic and visceral pain. Indication. The indication of Quadratus Lumborum Block, it varies from upper to lower abdominal surgery and some pelvic surgery. Surgeries like gastrectomy, pancreatic Whipple surgery, Miles, Dixon, appendectomy, inguinal hernia repair, renal transplantation, and some gynecological surgery like TAS and BSO, obstetric surgery like cesarean section, and orthopedic surgery like fractured neck of femur. These all can be included as an indication of the Quadratus Lumborum Block. And let's see what are the equipments that are needed for this Quadratus Lumborum Block. Low frequency linear transducer, 21 to 24 gauge, about 10 centimeter bevel needle, local anesthetic, sterile preparation including transducer cover. Patient positioning. Patients are generally placed in a lateral decubitus position, and some may also prefer the supine position. Abdomen and back of the patient is exposed and knee is flexed a little. The procedure. Quadratus Lumborum Block should be performed under aseptic precautions. Firstly, the painting and draping is done. After that, the two landmark, costal margin and iliac crest, they are identified. After that, the ultrasound probe is placed about the level of the umbilicus between these two landmarks. And now let's talk about the ultrasound anatomy. Muscles, they are basically hypoechoic. Fascia, they are very hyperechoic. Bowels, they generally move. Bones are very hypoechoic in comparison to muscles. The different layers of abdominal wall are identified in the ultrasound. The outermost layer is the skin and the subcutaneous tissue. Below that is external oblique muscle. Then comes internal oblique muscle. The innermost muscular layer is transverse abdominis muscle. And we can observe the ball movement below the transverse abdominis muscle and the peritoneum. After identifying these structures, the probe is moved more laterally towards the back of the patient. When all these three muscles are about to converge, then comes the Quadratus Lumborum muscle. Below this Quadratus Lumborum muscle lies psoas major muscle. When the probe is moved further, the erector spinae and the vertebra is also seen more posteriorly. When the Quadratus Lumborum muscle and psoas major muscle are identified, then the needle is advanced from medial to lateral between the mid-axillary to posterior axillary line. And when the needle reaches the intermuscular plane between these two muscles, then test injection is done with 1 to 2 ml of NS. If the needle is at right position, then around 30 ml of 0.375 mg of ropivacaine, the selected local anesthetic, is injected and the block is performed. The approaches of Quadratus Lumborum Block. There are basically 4 approaches of Quadratus Lumborum Block. The QL1, this is the first approach that involves deposition of local anesthetic in the anterior lateral aspect of the Quadratus Lumborum muscle. The second approach, QL2, this approach involves the deposition of local anesthetic in the posterior lateral aspect of the Quadratus Lumborum muscle. QL3 is the next approach of Quadratus Lumborum Block that involves deposition of local anesthetic between intermuscular plane of Quadratus Lumborum muscle and the psoas major muscle that we explained in this video. And lastly, the fourth approach is the intramuscular approach of QL block in which the local anesthetic is deposited within the QL muscle. If the incision involves midline or both side incision, then the block should be performed in both sides. And lastly, let's talk about the comparison between tab block and QL block. Since tab block, they are inconsistent with variable wound coverage, so they might require combination blocks such as rectus sheath block and ilioinguinal iliohypogastric block, and so on. Not only this, tab block also has a short block window. That means patient might require additional analgesics during post-operative period. The use of catheters for bolus and infusion in case of tab block and its associated risks can be avoided with the Quadratus Lumborum Block, since it has the longer duration of analgesia. Since this Quadratus Lumborum Block, they have the wider dermatomal coverage. This Quadratus Lumborum Block, it not only serves as the passage for the thoracic paravertebral spread of local anesthesia, and there is thoracolumbar fascia, which consists of high density of network of sympathetic fibers as well as mechanoreceptors. This might be the component that is responsible for the effectiveness of Quadratus Lumborum Block over transversus abdominis plane block.